what I thought we could just sort of talk through today, and this can be totally informal and casual since it's just you, and so I want it to be useful and relevant, is just to share with you about how, at Hopkins at least, we try to organize our thinking about mental health issues. Barbara, you can go to the next slide. So, you know, people have different frameworks that they use. You've probably heard of the biopsychosocial model or other theoretical frameworks like an analytic framework or behavioral interventions or behavioral ways of thinking or Vygotsky's social emotional learning, other things like that. We don't use any of those, mostly because we find them constraining and ultimately not as helpful as we need something to be to actually take care of patients. So what we use, and next slide, is something that Paul McHugh and Philip Slavny, who are at Hopkins, both retired now, developed quite a number of years ago, and we call it the perspectives of psychiatry. And really they are 4 different ways of understanding a person and their strengths, weaknesses, problems, issues, situation, whatever it may be. And each one uses a different kind of reasoning, and they are not mutually exclusive. And I think that's one of the things that makes this very powerful. And it's powerful not just for mental health issues, but it works for any kind of issue at all that a person might have. Next slide. So when we talk about the different perspectives, basically the disease perspective, what we're talking about is what a person has. The dimensional perspective, we're talking about what a person is. Behavioral perspective is what a person does, and life story or life events are what a person experiences. So if we go to the next slide and really focus just on diseases and what a person has, this is really what you do all day, every day, okay? It's, next slide, it's basically a categorical reasoning. You're looking for the broken part. You look for symptoms that tend to cluster together. You understand that there's a course of illness and an epidemiology that goes along with that. Maybe you understand the pathophysiology of what's going on. It's like CHF. You know, a patient presents with shortness of breath, swollen ankles, and irregular heartbeat. Okay, they have AFib, and now they're in a little CHF because of that. And we recognize that as a set syndrome. And we actually know in a lot of medical fields what the pathophysiology is that gets us there. In the world of psychiatry, not so much. So although we still take the same approach because there are the same set of pattern recognition and syndrome issues, we don't necessarily understand the pathophysiology the way we would like to when it comes to what it is we're doing. Does that make sense?
Yes.
Okay. So I think, Barbara, you can go to the next slide. So in the world of psychiatry, though, there are some things that we need to think about as diseases, or we're going to totally miss the boat. And go on to the next slide. I think it should be the one with the list of diseases.
Yeah.
Yeah, okay. So if we're not thinking of these as diseases, we're really not optimally caring for our patients, right? So autism, Alzheimer's, schizophrenia, manic depressive illness, unipolar depression, things like that, we really need to think of those as diseases. And the reality is that all of those have a course of illness, family and genetic vulnerabilities, epidemiology, and symptoms. You know, we look for schizophrenia, we look for particular symptoms. We don't look for the meaning that those symptoms have, we just look for those symptoms and that syndrome, and we call it schizophrenia. So very similar to something like CHF or asthma or something else. Those are diseases, and we need to think of them as diseases and work with them as diseases. And we'll come back to what that means from a treatment standpoint. If we go to the next slide and we think about what a dimensional perspective is, this is really about who somebody is. So a disease is what somebody has, and it kind of it befalls them. You know, it falls down out of the sky and hits them. Dimension is what somebody is. And this is, go to the next slide, this is really based on the idea that there is a normal distribution curve for every human trait you could think of. So people have so much height, so many IQ points, they're more active or less active, they're more pessimistic or optimistic, they are worriers or they're carefree, they're risk takers or they're timid. You know, you could think of a million different traits, and they would all be distributed in a fairly normal distribution in the population. There's nothing inherently good or bad about where you fall on that curve for any particular trait. It's just that you have more or less of it. However, when you interact with the world and you're at a tail of that curve, you may have trouble. So if you are 8 feet tall, getting in a VW Beetle is going to be a problem. If you are 2 feet tall, you're going to have other kinds of difficulties. So it's really the interaction between your dimensional qualities and life that can generate problems. So we sometimes think about the very, 2 standard deviations above or below the mean as being disordered, but it really is that they're disordered in the context of interacting with the environment. Okay. And if you can go through the next slide quickly and then just go to the one after that, which has the graph on it. That
this
one.
That one?
Well, I don't have it in front of me. It's got a normal distribution.
Sorry, I'm on the bell curve right now.
Yeah, that one. So that you can see, if you're at one of the extremes, and like in the world of kids, when a kid has a very low IQ and they have to go out into the world and be with other kids and go to school, they're going to have trouble. We also see, though, kids who have really high IQs often have trouble, too, because they're not like their peers. They can be odd and all kinds of things. So if you go to the next slide. So from a dimensional perspective, so the disease perspective, we think about schizophrenia, manic depressive illness, autism. From a dimensional perspective, we're thinking about somebody's temperament or personality, their intelligence, their learning issues, their activity level, their sort of mood with respect to their baseline, glass half empty or half full, and then worrier or carefree. And that's a very different set of issues than whether or not you have autism. Okay. The next perspective, next slide, is the behavioral perspective. And this one is a little bit harder sometimes to wrap our heads around, but it's based on the idea, next slide, that there are hardwired behaviors to eat, sleep, drink, sex, thirst, things like that. And sometimes the target of those goes awry, but basically all of those behaviors are shaped by behavioral forces. And so we think about things that somebody does, a behavior, in a very strict, really behavioral way. So there's if you look on the next slide, an antecedent behavior and a consequence. And if you manipulate antecedents and consequences, you can either increase or decrease the likelihood of a behavior happening. So in the world of kids, what falls into these categories really is things like eating disorders, substance use, things like that, which is listed on the next slide. But I would say in kids, we also talk about other naughty behaviors, aggression, lying, stealing, things like that, the things that the parents bring their kids in to see us, and they say he's out of control. And that's not necessarily part of a disease syndrome, and it's not necessarily part of a temperament, but we definitely see naughty kids. We also see kids with eating disorders, sleep problems, and substance use problems and whatnot. But naughty behaviors are a function of antecedents, behaviors, and consequences. Okay. And then the last perspective, next slide, is life story or life events, and that has to do with what people experience. So the next slide. And this is really that what happens to people generates a narrative, and how people understand their story and make meaningful connections is their script and their narrative for their life. And sometimes what we need to do to help people is help them re-script their narrative. And that's what psychotherapy can be about. And that is, the next slide, is about the relationship between setting, sequence, and outcome, and how somebody kind of understands what it is their situation means to them and the connections that somebody's making. So the next slide. So things that would be best understood from this way of understanding would be loss, grief, abuse and neglect, traumatic experiences, moves, other kinds of things that happen in people's lives. Again, very different from autism, very different from shyness or low IQ, and very different from naughty behaviors, but these are still really important things that happen in people's lives. So, are you with me so far?
Yes.
Yeah.
Okay.
I have a question about Emily, the setting, sequence, and outcome. Can you go over a little bit more?
Well, it really has to do with how somebody understands what happened in their life, the sequence of events that they've experienced, and how they see that impacting the outcome in their world. And people connect dots from their narrative, the things in their history that we wouldn't necessarily connect the dots that way. And sometimes they're very healthy connect the dots, and sometimes they're not so healthy connect the dots. So, for example, a common dilemma is somebody who has had a terrible event in their childhood, say they've been abused. That becomes the defining quality of who they are. And it's the only part of their story that they use to make sense out of everything else that happens in their life. It either happens because I'm a victim or because so-and-so did that to me. Now I'm ruined, so everything is ruined. And you can color that whole frame by one particular event. Alternatively, another person might not view it that way. They might say, well, that happened to me, but I'm not going to define my narrative by that terrible event. Okay. Now, the events that we think about as being life stories are not all bad events. They can be good events too. Sometimes we forget that. But good events, how does somebody make use of the good events in their life as well? And so it's the story we tell about ourselves. But sometimes that story doesn't really make as much sense, or it isn't as adaptive as it could be. So if we look at the next slide, if a disease is what somebody has, our responsibility is to treat it, or if not to cure, at least to ameliorate symptoms. In the dimensional perspective, we're not very good at changing somebody's personality or temperament or IQ, but we sure can provide guidance and counsel so they can make sure that they know their strengths and weaknesses and make sure they get into the right settings. So, for example, youngsters who have intellectual disability need to be in a special education classroom, right? Or they're not going to do well. So that's recognizing somebody's dimensional vulnerabilities and providing guidance on the educational setting to maximize their outcome. From a behavior perspective, our goal there is to interrupt behavior. We really don't have treatments for eating disorders, substance use, naughty behavior, whatever it might be, other than to say, don't do that anymore. Right? We ask people not to drink, not to use drugs. We tell people with anorexia that they have to eat, and we change the consequences for naughty behavior. So we're trying to get them to stop doing it. Now, that doesn't mean that there probably aren't genetic risks for who develops an eating disorder problem or a substance use problem. And, there are sociopolitics associated with being called a disease. If you're a disease, you get NIH funding and recognition and status. So it doesn't mean that we don't have aspects to substance use that have syndrome qualities. But if we have to really think through, if we only treat it the way we treat schizophrenia or autism, we're going to miss the boat, because really we have to make sure that that person stops doing that problem behavior. There's nothing that somebody can do when they have schizophrenia or autism that if they stop doing it, they no longer meet the criteria for that diagnosis. Right? They have it. It fell upon them. But you can stop having a behavior problem if you stop the behavior. So it's a very different way of understanding as a primary way of understanding. And then from a life story standpoint, it's really about re-scripting what I was mentioning earlier. From a prevention standpoint, next slide, from a disease standpoint, we want to try to interrupt the pathophysiology of any disease. Unfortunately, we don't really know much about our pathophysiology, but we do know that kids who are in a family where there's, for example, affective illness are at greater risk. So people are beginning to look at, can we do CBT, preventive CBT, or children of parents with anxiety disorders, children of parents with affective illness, to try to decrease or rather increase the threshold at which that illness might be precipitated out. From a dimensional perspective, it's all about, this is what pediatricians do all the time. It's anticipatory guidance, knowing who that kid is and, oh, Mom, you're going to have a little trouble with this next phase. We better work on that because you're kind of anxious and this kid's going to be a risk taker, so we're going to need to be prepared for that. From a behavioral standpoint, it's all about antecedents and consequences. So it's teaching behavioral management to parents. Not that they necessarily want to learn it. That's a whole other problem because it's hard work. But that's what we do. And, if you can teach parents early how to navigate toddlerhood well, the chance of them navigating the next developmental phase is going to be better. And then from a life story, when there are tough life circumstances, early intervention rather than waiting for there to be maladaptive responses can be very helpful. I would say that there's no inherent hierarchy. If we look at the next slide, there's no inherent hierarchy of these perspectives. That said, we never want to miss a disease. Okay, you never want to miss the worst headache of the life, which is a subarachnoid bleed. You never want to miss a disease because we can treat that, maybe cure it, fix it, whatever. We always need to be thinking about behavioral treatments to stop behavioral difficulties, and a disease may still also have behavioral aspects to it. The dimensional issues are going to require counseling and guidance that we might need to get more data about. But the life story is really what guides the conduct of an evaluation, all the education, and is really the front door to everything we do. Because if you don't listen to the patient's story and validate it, they don't come back. So even if you're correct that what they have is a disease, they don't care because they don't like the way you talk to them. So I would say that disease and life story is the front door. Disease we never want to miss. And the dimension is going to inform how we work with the person, and the behavioral perspective is going to inform some of the practical things that we're going to have to do. Now, if you look at the next slide, there are a lot of tensions, though, and it's not always so straightforward what's going on. I would say that a lot of the youngsters that we work with, certainly the ones that come into the hospital on an inpatient unit, there's often a tension between, is this a dimensionally vulnerable youngster, maybe a low IQ kid or a language disordered kid who has trouble making himself understood in the world, gets frustrated, is in the wrong classroom, can't manage himself, gets frustrated, starts using his arms and legs because he can't use his words very successfully, and is labeled naughty and disruptive, and maybe he has ADHD. But maybe it's really just a dimensionally vulnerable kid in the wrong setting, and so we're seeing predictable behavior problems that would go away if we had been smart enough to figure out that he had a low IQ or an LD and put him in the right classroom. So not everything that is wrinkles and squiggles or is off task means they have ADHD and a disease problem. And yet many of those kids will get started on a stimulant, and there's a missed opportunity potentially to think, maybe this is a dimensional problem, and we have them in the wrong context, and we're going to get predictable behavior problems when that happens. Okay. Sometimes it's a dimensionally vulnerable kid in tough life circumstances developing predictable behavior problems, and they have a disease. We can have an autistic kid who has, say they became homeless. That's unbelievably destabilizing for a youngster with autism, loses routine, all of that. Also has a language problem inherent with their autism, can't make their distress known, starts with all kinds of self-injury or aggressive behavior, so you can get all of that going on at the same time. I think what's powerful about the perspectives is that you can use them to think about why this patient presenting with this right now. It builds the story of the person that helps us understand their problems differently than just a list of symptoms and a list of diagnoses. So like that youngster who's having trouble at school, well, maybe a parent just was incarcerated or passed away, and they're stressed. The other parent isn't as emotionally available. They don't know how to use their words to ask for help or guidance or express their distress, and they're just struggling. That combination, and maybe they also have an intellectual disability. Maybe they also have an anxiety disorder. So you can get the confluence of these issues becomes much easier, I think, to explain than just listing the DSM diagnoses. And it creates a person for whom you can then think about, how do I want to intervene? What do I need to do first, second, and third? How do I want to sequence treatment for this youngster, given that that's how I'm putting the story together?
Kristen again. I'm seeing quite a few young people, and I'm talking about under 5-year-olds who have gone through what they're calling adverse life experiences or events, and their primary symptoms are lack of self-regulation, and it looks like ADHD in kids who are quite young. Some of these kids start having symptoms when they're less than 2 years old, and trying to figure out a way, and they almost always have the backstory of inconsistent parenting and poverty and homelessness and possibly parental drug use, often parental drug use, and maybe a single mom with a lot of different boyfriends in and out of the house, et cetera. And so we're struggling to figure out how to help these kids, and how do you so this is a problem that kind of that your perspectives approach seems to fit well with, although a lot of overlapping among the different 4 categories. But then, are there any effective treatments for this? And other than I know I have actually 2 perspectives. One is that we're often working with an impaired parent, so knowing quite how to approach that, and then knowing when it becomes rises to the level of child abuse. Because when we look back, we just, or when we're in the middle of it, we often wish we could just have a parent transplant. But that doesn't always fix everything either, and these children are often impaired for a long time. So any thoughts on that problem?
Yeah, I think that's sadly not an uncommon situation that many of us see, and I think you're right that those kids probably don't have ADHD. Now, they may not have great protoplasm, given if they were, exposed to in utero and things like that. They may have dimensional vulnerabilities that make their brain not so good. It may be that they have developmental delays because they've either been understimulated because their parents are unavailable. They may have language problems and other kinds of things like that. And then they have behavior problems because nobody is creating a structure and a scaffold for them to be able to navigate, and life is very overwhelming. So they get affectively overwhelmed by the world and use their arms and legs because that's all they got. So it is a very common scenario, and some of those kids probably have a risk to having ADHD. Some of them may have a risk to go on to have an anxiety problem, but at that early age, it's usually more environment interacting with their dimension, and then they develop predictable behavior problems. From an intervention standpoint, the most important thing is parent management training, but as you note, a lot of these parents are either not ready, not able, not willing to do the kind of work. One of the strategies that can be helpful is if there's any kind of under 5, like a day hospital or a day program or a PRP that will work with parents with the youngsters in the program. Or even like some Head Starts will have those kinds of programming for parents. They have to come in, or sometimes it is even court-ordered as a condition of keeping the youngster rather than having them removed, is that the parent has to participate in these kinds of parenting interventions. The challenge is that many of these parents were also underparented, so that they don't necessarily have an underlying skill set. So you're really teaching 2 children on some level because they've never learned how to do this. And it's hard.
That's a really good reminder because it's easy to get frustrated with the parents. And we're fortunate in Vermont. We have some pretty rich early intervention programs and daycare / preschool, and these parents often call it school for their kids, even when their kid is 9 months old. And they can be in full-time care where they get a lot more nurturing. And I'm sure that's helpful. I think some of these parents don't participate as fully as they could. They drop the kids off, and they often don't interact with the school, although they're encouraged to. So but maybe that I need to get stronger about encouraging parents to take advantage of the education for themselves there. But it's a little awkward. You got to learn how to be a better parent. So rephrasing that in a different way so that they don't get the impression that I think they're a bad parent.
Right. So one of the things that I'll sometimes say, because I think you make a really good point, because these parents drive us nuts. Because, come on, it's not that hard, right? Just do the right thing, right? But I think the idea, like what I will often say to a family is, you have a youngster that is harder than the average bear to parent, okay? In order to parent that youngster, you need industrial strength parenting. And in order to have industrial strength parenting, you need to be at 150% of yourself. How are you doing? Are you at like your best right now? Because this kid is hard to parent, and you need every skill set in your book. And if you're not 100% or 120%, 150%, then let's work on you first, and then we'll get to the youngster. And I just say that the kid needs more than most kids, and so we need to tune up the parents. That seems to be a lot easier for parents to hear than, they're not doing a good job.
Yeah, that's a really good tack to take, and it's mostly true, which is why you can be sincere when you're delivering it.
Exactly.
And we don't have to go into how that child got to that point. We can just start from where they are now.
Right.
Exactly. And
I think
when we ask parents to do behavior work, the reality is things often get worse before they get better, because the youngster starts to say, "What? I'm sorry, I don't like this new set of rules you're doing," and they will push back. And so often parents, if they're not prepared for it to get worse, they will say, "Oh, I tried behavior thing, it made him worse, I'm not doing it again." So we have to not only get them tuned up, but we also have to get them ready to do something that's going to get worse before it gets better, which is kind of counterintuitive to a lot of our families.
Right.
But that's true of any behavioral plan. It gets worse probably for about at least 10 days before things begin to settle down. So families need to be prepared for that as well. And that's harder. And sometimes I will also, even when parents say they really, really want to do it, I'll sometimes say, well, I'm not really sure. I think we should wait so that they come begging rather than pushing it. Because if you push before you think they're really ready, it doesn't work. And then we sometimes only have one chance. Because then they say, no, I tried it, I'm never doing that again. So I would rather a family say, no, I'm really, really sure I'm ready to do it. I please, and then give it a go. And if they say they're just not willing to do it, I might also say, well, what would it take? What would Johnny's behavior have to look like before you would consider it? How bad would it have to get? Do you have to be expelled from kindergarten? What do you think it would look like? And have a very serious conversation about that so that I can understand what their parameters are. And then we'll say sometimes, okay, let's wait. But now that I know what you think a flag is, when that flag happens, I'm going to call it. And then can we agree that if that happens, we're back in it together? So again, you're kind of laying the groundwork for what you know is going to happen. If they don't do this now, it's going to get worse. So you ask them to create that roadmap for when they might be willing to consider it.
Okay.
Well, I think that, Emily, I think that, let me just go back to perspectives and think about the primary care pediatric point of view. I think we're thinking of little babies also, not just preschool tantruming kids. And one thing I feel, I love your perspectives. I think it's very, very useful clinically. But the one place where I wonder about is that I'm thinking the relationship could be a disorder. And
the what?
The relationship could be disordered itself. The relationship, the parent-child relationship.
That's life story. Yes, absolutely.
Not just it doesn't come up to any of those things you talked about individuals. And I think that when we as pediatricians think about those little babies in particular, that's what we're thinking about. And the infant mental health group, the DC 0 to 3, I think that's where they have a point.
That is within the perspective. The thing is, when you work with kids, you have multiple perspectives going on because you have multiple players. So each person, each mother, each father, each aunt, each grandma, whoever it is, has their own perspective. So one of the things that makes child work more difficult is that you have to understand the adult psychopathology. You have to understand the dimensional issues of the mother. You have to understand the life story issues of the parent, and then how that all interacts. So when we are doing an evaluation of a youngster, it's not just what is going on for the kid. It's what's going on for the parent, what's going on in the interaction, and that's always part of the child psych eval, and sort of putting that all together, because the family is a separate unit, separate from the kid, separate from the parent.
Right. Oh, okay. Well, and I like your point about, for pediatricians especially, when in doubt, blame it on the infant.
Right.
I think the tendency is for pediatricians to see, oh, this is a bad parent,
right.
And as a little subtler to say, this is a difficult baby, anybody would have trouble. Let's that disarms the parent. What
right.
you've done immediately is taking them off the hook, and that's a great intervention in itself. And there are the groups when you talked about those kinds of kids there, and we began talking about different kinds of therapists. Well, I think getting a therapist who works with parents and infants together is an unusual subgroup, but I think you might be able to find them, and that's a different kind of perspective than some of these others.
I think just to mention some resources that might be of interest to the people on the call, the Incredible Years program can be exported. People can train in the Incredible Years, and that really does a combination of supporting the parents in getting new parenting skills and recognizing that what the child brings to the plate. That's mostly for younger kids. The Healthy Steps program has also had some success in ameliorating the differences between families that are experiencing a lot of the parents had adverse childhood experiences of their own. they can sometimes quiet it down with the kind of support that comes along with that paraprofessional, or I should say professional, because they're often psychologists who work with families in a pediatric office. Those are some resources that have some evidence behind them for helping to rebuild parent relationships and might be available in your community. It's worth asking, and those you can actually go to the Incredible Years website and find out whether you've got some of these Incredible Years trained in your area. Here in Maryland, we have the family support centers that try to do some of that by providing some child care and job training and parenting education all in one kind of a facility. I just wish there were more of it.
The other, in terms of tools, in Chatez, especially for these young kids, as we were just talking about that case, we have something called Chatez 0 to 3 that I don't know if you guys are using it, but it gets at the typical kinds of things, eating and sleeping, that pediatricians are required to document. But if the parent expresses concern, it goes a little further and can suggest these infant mental health diagnoses, which are helpful because there are pieces where the parents are motivated and they say, he's not sleeping. And there are lots of other things that the kid's not regulated, you mentioned, but the parent may be more motivated to get some sleep than anything else. And so you do want to find out where does the parent motivate it, and having some diagnostic labels is sometimes a helpful place to get that motivation and to make a better referral and communicate that information. So I think that's one tool. Any other tools you want to suggest from Chatez Farm?
I just think that using the Adverse Childhood Experiences questionnaire and the SEEK, which is Safe Environment for Every Kid, will help you figure out some things about the current life story, which often point to the previous life story. So it detects things like intimate partner violence and depression and food insecurity and substance use. And in the case of the ACE, it's asking about things that happened when you were young. And often the story is written by those things that happened when you were young. Not always written. There are people who come through those experiences and don't have the morbidity associated with them, but a lot of people do. And my philosophy about it is that oftentimes those adverse childhood experiences are what makes the life story that goes awry.
Well, the other thing that
I'd like to hear what Emily thinks about that idea, actually.
Absolutely.
Let me just make one other comment, Barb. There's a very simple tool in Chatez that asks what's the best part and what's the hardest part at each checkup visit. And sometimes, they come in with a chief complaint of a rash, whatever it is, and just by asking, what's the hardest for them, on their perspective, that's what they're willing to talk about, the words they're willing to use. But that's not sufficient, because if you're not able to acknowledge what they're enjoying, that this kid, they like to smile and how healthy he is or whatever they can come up with, you begin to have a discussion very simply by this is the complaint they have, not the chief complaint in a medical setting, but the complaint they have for Aunt Betty and the neighbors, and what's driving them to be motivated, and a balanced view of what they're doing well.